Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. And today we're going to be talking about pediatric bipolar disorder. And wherever I go, and here at NEI, we get asked questions about this all the time. And with me is a very good friend and a perfect expert to have this discussion with, Dr. Manpreet Singh from UC Davis. Hello, Manpreet.
Hi, Dr. Cutler. How are you, Andy? It's so great to see you again. Thanks for having me have this talk with you.
Absolutely. Well, we're basically continuing a conversation that we have on the stage and off the stage all the time. I'm going to start out by saying, Manpreet, the whole concept of pediatric bipolar disorders seems to still be a little controversial. I remember a few years ago it was very controversial, but it's still controversial. And I understand why, but what's your take on that? Why do you think it's controversial?
It's a great question to ponder, but then also remind ourselves that this is very normal for many complex conditions like bipolar disorder, where diagnosis is difficult even if you're an adult. So why would it surprise us that it's difficult to diagnose in kids as well? People on average spend a decade or more being diagnosed with bipolar disorder. It's no wonder. But if you ask adults, when did their most common age of onset for mania symptoms occur, it happened in childhood or adolescence. 2/3 of people, adults, will report that their first symptoms started in childhood or adolescence. So what are we doing to potentially evaluate for it in childhood and adolescence? And what are we doing that might miss it? So the controversies of over and under diagnosis are as a tale as old as time. And Kraepelin did a very nice job, Emil Kraepelin, when he kind of observed patients with bipolar disorder, saw that the initial symptom phase of onset of classic mania, sometimes people just have their first manic episode and it just declares itself. Whereas other people have a prodrome. They have these sub-threshold symptoms that bubble. Maybe they have a depression that just isn't treated with an antidepressant very effectively, or that they have these massive number of comorbidities like anxiety and attentional dysfunction, or even substance use, that winds up confusing the diagnostic picture so that the classic mania that is usually quite declarative is just not as obvious. So we see this from the retrospectoscope all the time. We see kids with classic mania who've had bubbling symptoms, functional hypomania, if you will, got them into an IV school or something else that really was quite impressive. And then as soon as the stress of college or a change in environment or some other interaction to the symptoms that were bubbling in the background, the straw that broke the camel's back, and a classic manic episode emerges, and all of a sudden, why didn't we think of this as a part of our differential? So I perceive that there's lots of very good reasons why we have difficulties diagnosing bipolar disorder in youth, and especially when the symptom constellations aren't so clear.
Yeah. But can it also present with depression first and then the mania later? And that's another way you miss it?
Yeah, absolutely. So mania is oftentimes preceded by depressions. And as I was mentioning before, it's like you got these manias that are classic. Sometimes they're they're preceded by depressions. And sometimes those depressions, you kind of got to watch for those depressions that are just not responding to classic antidepressant treatment. Sometimes people become more obviously manic when you treat them with an antidepressant to treat the depression. And then all of a sudden you realize, whoops, this is actually a bipolar depression rather than a unipolar one.
Well, someone's work who I've always greatly admired, and I'm sure you have too, is Barbara Geller and colleagues at WashU in St. Louis. And they did some amazing studies where they followed depressed kids and found that if your first episode of depression is 24 or under, that actually triples the odds that you're bipolar. So by definition, if we see depression in this young age group, we should have a high index of suspicion, don't you think?
It is true that depressions that start early are concerning, but one of the things we have to keep in mind is that that work that was done by Barbara Geller, as important as it was, occurred 25, 30 years ago. And a lot has happened since then in terms of the culminating, if you will, like the evolution towards more distress, the advent of technology in some ways, and other, again, ecological phenomena that have made the business of diagnosing mood disorders in youth much more complicated. So, we have to be thoughtful about what an early onset of depression indicates or could signal. We should always think about the totality of a mood syndrome. And so when you see somebody who's sad, a child who is sad, it is completely reasonable for you to evaluate for both depression and mania every single time, so you don't miss it. And so is it relevant to ask about mania in a child? Some people might say, kids can't get manic, but why can't they? Kids can have a cold just as much as they can have mania, just as much as they can have depression. The possibility of it is shouldn't be debated, but the probability of it might be very low compared to that adolescent phase when most commonly patients experience their first
Welcome
manic
to a
episode.
CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast description page or go to nei.global/podcast.
You'd find adults with bipolar disorder engaging in terms of impulsive behaviors. You have to adapt it to kids. Are they thinking that there's a superhero and jumping off of high places and thinking that they have the ability to do things that nobody else can do? And is it beyond usual imagination? And does it seem like it's impulse control problems that are really out of context or expected for their developmental stage? So there are ways, and Barbara Geller actually was one of the first scholars to help us develop a language for understanding how mania presents in youth. So now we can use those semi-structured interviews and those questions to adapt the phenomenon of mania to younger populations. So very grateful for her work to be able to create a language of how we can understand mania in developmentally younger populations.
Well, one of the studies I remember and helped me with this one was in trying to differentiate ADHD from bipolar, which of course is not as easy as it may sound. When you see grandiosity or hypersexuality, that's not typical for ADHD. That tends to lean you towards bipolar. Is that still true?
Yeah. So here's another sort of general clinical pearl that I've really adapted with my patients, and that's that bipolar disorder can often be preceded by ADHD. ADHD might well be a prodrome to bipolar disorder, but classic bread and butter ADHD tends to get better with time. Kids, brain development occurs, more cognitive regulation occurs. Bipolar disorder, if untreated, doesn't get better with time. Unfortunately, it gets worse. And the distractibility and the nature of the distractibility that patients experience when they're having a manic episode is usually internal. I'm distracted by the racing thoughts in my head, not by the construction rig outside or something else. That's usually what people with ADHD experience. The kids with ADHD classically are distracted by whatever else is going on in their environment. And they're usually, if they're distracted or they're making mistakes or they're doing things that are poor impulse control, it's usually in good fun and usually not intended. Whoop, I didn't mean to do that. Whereas patients with bipolar disorder will rage for hours and will do things, speak out, impulsive, risk-taking behaviors at the cost of others. So these kinds of distinctions, even though there are some overlapping symptoms between ADHD and bipolar disorder, can definitely distinguish the two syndromes. And clinically, patients who experience both, you can kind of see what falls more in the camp of ADHD and more in the camp of bipolar disorder when you look at the core symptoms of mania. And the core symptoms of bipolar disorder are unmistakable. Elevated, expansive, euphoric moods or explosive irritability is unmistakable and really doesn't align with what you see in bread and butter ADHD. Now, the comorbidity is important to disentangle too, but once you've mood stabilized someone for mania, then whatever else is going on should remain if it's truly a comorbidity. If you've taken care of it with mood stabilization, you may not even need a stimulant.
Yeah, that's really helpful.
That's how I think about it.
Okay. Well, I'm going to get into that a little more in a second. I want to back up. You started talking a little bit about how bipolar might present a little differently in children versus adults. Can you continue to elaborate? You've taught me many things over the years about this, but for our audience, how might it present differently in children versus adults in other ways?
Right. So alluding back to the core cardinal symptoms of mania and how you elicit them from kids will do things that are impulsive, just again, by developmental stage that might be appropriate, but running away from home, taking undue risks. Kids don't work, so they're not necessarily resourced to gamble, but they might get an allowance that they give away, or they purchase things that they don't need and find themselves, maybe if sexuality is a question, pubertal development, kids are pretty horny and will find themselves, maybe engaging in sexual behaviors out of experimentation. But when you see kids that move beyond one or two partners or monogamous relationships or are really seeking, sexual encounters in ways that are maybe just above and beyond what would be expected for that stage of exploration, then you have to wonder if they're having, unfortunately, finding themselves having sexually transmitted diseases, or really finding themselves in other situations like getting in trouble with the law for excessive impulse control behaviors or recreational drug use that is above and beyond what would be expected. Those kinds of boundaries. And then academic performance is kind of interesting. Kids, because they don't work, this is the way we kind of are assessing their cognitive functioning, right? And bipolar disorder, if you're functionally hypomanic, can actually make you quite productive. And so you might see, in fact, kids, pulling all-nighters and doing quite well in school and hitting really, really difficult, complex topics in school, if they don't have ADHD, actually thriving academically. So it may look, for all intents and purposes, that a patient is doing quite well. But then when you delve in and ask about their moods, how are they feeling? When they are losing sleep during the week because they don't need it, are they catching up on the weekend? And if they're not, that's a red flag. So you have to adapt the kinds of things that we worry about in mania to a child's usual functioning. And that's how you can evaluate for the dig fast symptoms that we typically evaluate for in adults and adapt them to kids. And the grandiose delusions that kids have, you have to probe for reality testing. do they really believe that they can be Wayne Gretzky? Do they really believe that they can rap like, Kanye West and make it? And then you want to test and challenge their belief system to the level of how far does that reality testing go? And that can give a very useful sense of how impairing are these symptoms to the patient's cognition, to the patient's functioning, to the patient's day-to-day social and academic interactions.
Don't you also look for the episodic nature here? So when you're describing someone who's hypomanic and they may perform very well, but isn't that followed by periods then when they're not doing as well? Maybe if they get depressed or just they're not hypomanic. I mean, don't you look for variable performance also?
Absolutely. Another quintessential hallmark of mania is, of course, the episodic nature of it. And every symptom that you're evaluating for is relative to a baseline. So one of the other pieces to make sure that you evaluate for is for any symptom that you're eliciting from a patient, what was life like before this symptom came about? What is your functional baseline? And that is a very clear, that clearly needs to be established before you can get to a place of understanding how it's maladaptive for the patient, in addition to the temporal sequence of it. So understanding if it's happening in a period of time where 50% of the day, every single day for at least a week for a manic episode. Same true for hypomanic episodes, that they're 4 to 7 days. And then most kids wind up less in the bipolar 2 spectrum, I would say. I think that my clinical experience, I've seen kids have unspecified bipolar or very classic bipolar 1 disorder. The stuff in the middle is very difficult to capture because most kids will describe 2 to 3 days or at least a week. And it's those 2 to 3 days that make it very difficult to understand the degree to which this is impairing for a child. And so, and what's interesting, there's work being done in the University of Pittsburgh where there was longitudinal evaluation of children with or at risk for bipolar disorder. And the curious findings from the BIOS study that longitudinally followed a youth with bipolar disorder is that a family history was very predictive of conversion to bipolar 1 or 2. And it was the case that the patients who have 2 to 3 days of subthreshold manias are actually quite impaired by them. So these kids are not doing okay. They're treatment seeking. They're finding themselves in clinics. Even though they're not meeting the time criteria, they're quite impaired in school, in their social interactions, in their family life. So these are not kids who are, doing okay and then well until not well kind of deal. They're actually quite impaired by these episodes of unspecified bipolar symptoms.
I don't know about you, Manpreet, but I have trouble with the time stamping of this, if you will. I find, at least certainly when I'm dealing with adults, it's hard for an adult to say, I just started getting manic this past Tuesday. It just is sometimes indistinct and harder. So sometimes I like what you're saying about using impairment as your guide to some degree. If there's impairment,
change from baseline,
yeah, then they still may need treatment, if you will. Let's back up. Can you? You've talked a little bit about what to look for, but walk us through your evaluation process and if there are any screening tools or instruments you like to use. You've already talked about the primacy of family history, which I agree with you. This is a highly genetic condition, for example. But just thinking about the evaluation, how do you think about it?
Yeah, so I have often the opportunity to do an evaluation of a patient who is looking to understand whether they have bipolar disorder. Bipolar disorder is more commonly ruled out than it is ruled in part because it's not frequent to discover a classic mania in an outpatient setting. Inpatient setting is a different ballgame. But if we're talking about an outpatient evaluation of bipolar disorder, more often than not, what I see are a pretty wide differential. And the way that I try to evaluate and rule out bipolar disorder pretty quickly is I try to evaluate for a manic episode. So I'm looking for a change from baseline of 50% of the day, every day for at least a week of elevated euphoric or explosive irritability, right? And if I can't find a week or a hospitalization or a dramatic change from baseline where that manic episode has occurred, then I know that I'm going to need to take more time to look at the stuff that you said is more difficult, which is the subthreshold stuff, right? Anything less than a bipolar 1 or 2 is a lot of evaluation of, well, how long and what time frame and what are the associated symptoms and are they occurring alongside in that 2 to 3 day window? And then if that's not happening, if I'm not noticing that, then I can rule out bipolar disorder and then go down the path of my differential diagnosis. Is this really just bread and butter, depression, ADHD, an anxiety disorder, and make sure that I evaluate for those things as well? If it's very clear that there are these hypomanias, then I need to make sure that I'm following that over time. So it's not enough, I think, humbly, having now studied kids for 20 years with these constellation of symptoms, to see a patient once and be definitive about a diagnosis of bipolar disorder. These symptoms are they're too serious and they're too important for us to wave off. So I like to then give, once I've done my evaluation, and I will talk about screeners and other things in a moment, I like to give patients mood charts. There's now paper mood charts that they can make. They can do it on an app. There's several apps out there that people can engage with, some that are very fun. And for kids, there's like rainbows and colors that they can ascribe to their moods, and have them come back in 2 to 3 weeks with a mood chart where we can kind of really confirm what the pattern of their moods are in any given time. And if we can do that, that enriches the evaluation. Now, if you're in the business of, screening for depression and anxiety, your clinic is doing a PHQ-9 and a GAD-7 because that's now in primary care. It's in our psychiatric practices. We have the ability to do that. Wouldn't it be great if we had a rapid mood screener in there as well? For adults, we can use a 6-question mania screener for people who present with depression to evaluate for early onset depressions, to evaluate for other, mania symptoms that are very important to screen for. I believe that every child that comes with depression symptoms should have an evaluation for mania symptoms. Just ask, if you're sad, has there ever been a time when you were cheerful, high, terrific, not your normal self, couldn't imagine life being better? That's the script I used. Cheerful, high, terrific, not your normal self, couldn't imagine life being better. If the answer is no, then you're done.
What about the irritability?
And then you ask that again.
Oh, yeah.
Okay, then you ask about irritability.
Oh,
so if irritability is, if you've ever been irritable, but to the level where you're physically, explosively irritable, breaking things, has that ever happened? And if the answer is no, then you shelf that for the next time they come in. Point being, you have to ask those questions every time someone comes in with any mood symptoms. And those are the screeners that I would say that are really more high yield than any other screener that you could potentially use. Unfortunately, we don't have a mania screener for kids, except there is a general behavioral checklist that Eric Youngstrom has validated for kids. It's called 7 Up and 7 Down, 7 questions about up moods and 7 questions about down moods. And that's been useful to screen for mania in kids, and that can be potentially useful for psychiatry clinics as well as primary care. But I would say, again, just asking about explosive irritability or cheerful, high, terrific, not your normal self, couldn't imagine life being better. Those kinds of questions, in addition to the low moods, are really very high yield for screening for mania in kids. And then doing that at every visit just makes sure that you don't miss it. That every single mood episode or every single opportunity that you have to evaluate for a patient with a mood problem should be comprehensive. It should evaluate for depression and mania at every single appointment.
Right. Now, didn't you also teach me that kids usually present with mixed episodes, that there's a lot of mixity, if you will?
Yeah. Let's add more complexity to the already complex picture, right, Andy? So Kraepelin observed this to be true too, that patients without discrete episodes may even experience roughening between depressions and manias. They might experience the juxtaposition or the overlap of mania and depressive symptoms. As confusing as that is, how is it possible for me to be up and down at the same time? It's an agitated state. It's maybe a rapidly cycling state. And kids will demonstrate that phenomenology in part because their brains are underdeveloped. And so when you have the layering of immature brains with these constellation of symptoms, they can look very, very similar to what we see in adults as mixed states or mixed features. The A's of mixed features, the anhedonia, the anxiety, the agitation, the attentional dysfunction, those are all things that can present, and anger, of course, that can present in use. And they look non-episodic, but if you're careful, you'll be able to see that these are symptoms that are actually heralding an episode. And so it's good for you to look for the kinds of symptoms that are likened to mixed features in addition to looking for an episode. So are you finding yourself more depressed, or are you finding yourself in a manic state, or did you experience one recently? You'll always see that, mixed features seem to be part of that constellation of worsening into an episode or coming out of an episode.
Got it. Yeah. What is the risk of suicide in kids with bipolar? It's fairly high in adults.
It is high in adults, and we do worry about suicide risk in undiagnosed bipolar youth. I often wonder if children who have completed suicide may have been undiagnosed with bipolar disorder. It's not that I don't believe that unipolar depression can't lead to that outcome. It's the acuity and the severity and the intensity of the depression, quality of the depression in bipolar depression that make me worried about the risk for suicide in an undiagnosed bipolar youth. And it's why it's so important for us to evaluate for the totality of the mood state in youth because of that risk. There are a few studies that have evaluated sort of the suicide rates and the epidemiology of suicide in bipolar youth. Unfortunately, since it is a relatively rare outcome, the frequency and the intensity of it is not high. Thankfully, we haven't seen a huge mortality rate. But what we do see that's pretty common is more hospitalizations in youth with bipolar disorder, often due to suicidal thinking, and more severe attempts. So the retrospective history I hear from kids who had these long, very, very untreatable depressions is that, I had this method that should have killed me, but it didn't. And you hear these histories and you think to yourself, wow, that was a very serious attempt that you had back when you were 14. And lo and behold, that followed with a very serious manic episode that came later. So this is a very common clinical phenomenon that I've seen in many patients that present to me in their first manic episode, is that they've had serious suicide attempts earlier because their depressions were so bad. It was a wonder that they survived.
Yeah. You know me. You've known me long enough now that you know I have all these sayings that I call Cutlerisms, and one of my Cutlerisms is: depressed patients attempt suicide, bipolars commit suicide. They do tend to use more lethal means, and sadly, they have a higher completion rate. So I resonate with what you're saying, definitely.
Right.
Okay, let's now shift gears. Let's assume, okay, we've made the diagnosis. How would you think about deciding on your first line treatment, on your, let's say your first medication choice? Of course, you're going to be using non-pharmacologic interventions. We'll talk about that in a minute.
Yeah, no, I always have to say for pediatrics, it's always very important to make the claim that we must start with non-pharmacological treatments for anything that presents, especially depressions, because we want to give the good college try for a psychotherapeutic intervention. But for bipolar disorder, I think your instinct is right, Andy, that psychotherapeutic interventions are not going to mood stabilize a patient in and of itself. So for classic manic episode, manic or mixed episode, you must treat with FDA approved. And we have many options in that way. We have 5 or 6 different options that are approved for bipolar 1 disorder down to age 10. And all of them are second-generation antipsychotics for an acute manic or mixed episode. Quetiapine, interestingly, is the exception to mixed features. You don't have approval for a mixed episode for quetiapine, but if you're manic, you can be
That's
approved.
Historically, Manpreet. I actually did those studies. That's historically because they just didn't include them for some reason. They thought that was going to be harder to treat or something, but you're right.
Right.
Yeah.
But nevertheless, you have a fair number of second-generation antipsychotics. Lithium has been grandfathered and approved down to age 7, and we have actually very good data for its efficacy and safety in youth. Work done by Bob Finling and others that have demonstrated time and again that we can use lithium for mood stabilization in youth. Depakote has an interesting history. There was an attempt to evaluate Depakote's efficacy and safety, but it was the extended release form that was used, and the trial was negative. So it has not been FDA approved. And people have been less keen on Depakote, especially for its side effects.
Yes, I worry about the risks.
We're not talking about Depakote much anymore.
I worry about the risks, to be honest, yeah. I think we have other options, yeah.
But now the new sort of line of treatments that have been understood to be a very important unmet need for youth is to treat bipolar depression. And so for bipolar 1 depression, we now have olanzapine fluoxetine combination and lurasidone approved. And we have the active registrational trials that are currently underway to evaluate efficacy and safety of cariprazine and for lumateperone, both of which are currently under phase 3 evaluation extension studies that are being done in kids to evaluate safety and efficacy. And my hope is that those 2 medications can be added to the armamentarium for novel therapies that are maybe going to be better tolerated than the ones that we currently have FDA approved.
Yeah, what I like about both of those is not much weight gain and no prolactin elevation, which is not good in developing kids, as you, of course, know. And at least in the case of lumateperone, very low risk of movement disorders, which is also something I worry about. So yeah, that is exciting. Now, you taught me something else, Manpreet, I have to tell you. You taught me that lamotrigine is not such an effective treatment in children, that it's fine for adults, but doesn't seem to work as well. Is that still true?
Well, it's not that it's not effective. In some post hoc analyses, it's very clear that lamotrigine could be of utility. Kiki Chang and Melissa Del Bello have done some of this work to evaluate for the efficacy of lamotrigine. Unfortunately, it just hasn't performed very well in double-blind placebo-controlled trials. Open-label studies continue to demonstrate its efficacy. I kind of consider it as a second or third line. If I'm really looking for something for bipolar depression, people really fuss about Stevens-Johnson's rash in kids. And so then the dosing timeline winds up being really, really protracted. And so you have to wait a while to get it dosed up properly. And then you have to worry about the rash. So a lot of people have been a bit, I guess, down on lamotrigine, though it may have some utility for bipolar depression. It has not been FDA approved. And so when you have something else that's approved, you have to kind of go with that first. Off-label, I've used it occasionally for patients with bipolar depression, even as an augmentation or a combination with lithium. Where I can't seem to get the depressed phase under control with a monotherapeutic solution.
Yeah. My experience in the handful of kids and adolescents that I've treated for bipolar is that lamotrigine has not been as universally effective as I find it in adults. And, could be the differences in the brain development and all these other things. Or as you said, the dosing just isn't worked out, that kind of thing. Okay, I like lithium, boy, I got to tell you, I don't know, Manpreet, if you saw, August 6th, a landmark article came out, and I realize this is at the other end of the age spectrum, but it was published in Nature. The first author is Arun, A-R-U-N, and of course, who immediately texted me but our good friend Jonathan Meyer, who wrote the Lithium Handbook, and this article was stunning. It showed that there's lower levels of lithium in brains of people with Alzheimer's, and when they gave lithium orotate in particular to animals, mice in particular with dementia modeling, it tended to reverse and protect against some of these things. So I think lithium, because I agree with you that bipolar is probably progressive and it may even be neuroprogressive. And so, gosh, if this is true, what do you think about neuroprotection here?
I think that if there's, I'm going to say something fairly strong for someone who's a bit more tentative and speculative about most science that we have, but lithium, I think, is the closest medication that we have in psychiatry to being potentially disease-modifying. And that's a big, big statement because of the potential for neuroregeneration, gray matter, prefrontal gray matter loss that is reconstituted with lithium, in my mind, is a huge opportunity. The inositol pathway, under which mechanistically lithium functions, it has the key ingredients necessary. I wish it didn't have the kidney or renal off effects or the thyroid off effects that make it a little bit more problematic for those patients who just can't tolerate it. But for those patients that it works, I think that it is somewhat of a transformative treatment. And we have to be striving for cures in bipolar disorder. And we should be learning more about how lithium works to be able to iterate towards that kind of permanent benefit that kind of a medication provides. Most of the other medications that we have, as we well know, are really being evaluated in an acute setting. They're really symptom reducing more than anything else. They're not prophylactic and preventative in the ways that we need them to be, but we need to be studying whether second generation antipsychotics, third generation, whatever we want to call these. The nomenclature is not very good in my mind either, but these medications that we do have that we know to have a good effect in the short term, how do we understand their effect in the long term and study those treatments in that fashion?
Yeah. So lithium, Jonathan taught us, if you're going to use it, you give the whole dose once a day in the evening. That's a little less toxic to the kidneys. Right. And actually, we're learning now, Manpreet, it's less the inositol phosphate pathway. It's more the GSK3 beta. But it may also, look, lithium's one of those pleomorphic. It probably is doing more than
pleomorphic.
It's doing a lot of things.
It has multiple mechanisms.
Yes, it does. I think we have to be honest about that. Okay.
Yep.
I want to move on. I don't want to take up the whole podcast. I'm really enamored with lithium right now, but let's move on. Let's talk about the other kinds of interventions that maybe are evidence-based in addition to medication. And thank you for that really comprehensive summary. Oh, before we leave that, I have to ask you two things. One is, do you ever combine a traditional antidepressant with an atypical or with a lithium or something like that? Or is it just not something that you should do?
Sometimes there may be a scenario where an antidepressant can be beneficial, but only once if you have a documented manic episode, lifetime manic episode. You have to be very careful to use antidepressants unopposed. And so my general inclination is to be very thoughtful about when to use, but sometimes an antidepressant at a low dose can be very useful adjunctively to mood stabilization for breakthrough depressions. Again, I would try combinations before I go down that path, just because I know. But some of the reasons why we do that is because, don't forget, many of these patients have been exposed to antidepressants and have a positive affinity to them because maybe they did create a functional hypomania for them. And so when they're really depressed, that's what they know. And so you have to work around the business of understanding what's been mood stabilizing. And if it's a really recalcitrant, very difficult to treat depression that follows, I try to keep an open mind and be very educated. I should tell you that we did do a study to evaluate the efficacy of antidepressants in children who have a family history of bipolar disorder. And they presented with no lifetime manic episodes, so they were really very much just at risk based on family history. And they presented with bona fide depression or anxiety. They did not have any, other concomitant treatments except maybe a psychostimulant or an alpha agonist for comorbid ADHD. And they presented with depression or anxiety that was so bad that it didn't respond to therapy. You gotta, in that instance, do we treat with an antidepressant or not? Do we worry about them flipping into a mania because of the family history or not? And when we did this randomized controlled trial, it was the first randomized controlled trial to treat and target the depression or anxiety. And we found that the kids who were randomized to escitalopram had the same rates of side effects as the kids randomized to placebo. So it isn't the case necessarily. It might be the case that there are biological reasons, and we found imaging findings that may suggest there may be some biotypes that are very vulnerable to side effects. But right now, we cannot conclude that antidepressants are off the table for youth at risk.
Okay, that's helpful.
If they have never had a lifetime manic episode.
Got it.
If they've had a lifetime manic episode,
sure, then
all bets are off. You've got to go, you got to mood stabilize.
But wouldn't you still monitor?
Antidepressants, absolutely need to be monitored.
Yeah, I was just going to say that. I would watch that patient like a hawk, just to be careful.
100%.
Great. My second thing, and I think this can be pretty quick because I think we'll agree on this, is that because we know ADHD and bipolar are genetically linked. Frankly, they travel in the same families. They're both dopamine dysregulation, especially the prefrontal cortex, blah, blah, blah. There's lots of evidence that you can use a stimulant in a bipolar patient as long as they're mood stabilized with either lithium or an atypical. You would agree, right? Because it's still controversial.
Russ Sheffer did this study, and he randomized patients with and without, and it was very clear that you have... When you mood stabilize, once you mood stabilize, a psychostimulant can be a very useful adjunct.
And speaking of which, Roger McIntyre's first author on the asenapine trial in I believe it was adolescents down age 10, and they allowed stimulants in that trial. And when they subanalyzed, there were no worse outcomes with the stimulant group added to the asenapine. So
that's right.
Yeah. Okay. Let's talk then about non-pharmacologic. Sorry, I interrupted that. Evidence-based non-pharmacologic, other things that we need to be doing.
So there are a number of evidence-based psychotherapies that have been implemented in youth with and at risk for bipolar disorder: family-focused therapy, social rhythms therapy, cognitive behavioral therapy. More broadly speaking, all of these are sort of some version of that in some ways or another, but are targeting different, social rhythms or family function. All of these are evidence-based psychotherapies that have been implemented in youth with and at risk for bipolar disorder and have demonstrated effects separate from a psychoeducation or a standardized control condition. So we're now well aware that there's an armamentarium of psychotherapies that are evidence-based that should absolutely be used in combination with pharmacotherapy in the treatment of youth with bipolar disorder. And I have to say that, these kids are complicated. Their family environments are complicated and often very chaotic. So having structured psychotherapy can be a tremendous help to the patient and can really promote one of the most important and essential cornerstones of treatment, which is adherence. Melissa Del Bello did a study in first episode manics, and she found after their hospitalization, 12 months later, only a third of youth, adolescents, stayed on their medication. I did a similar study in first episode manics, and I found the same abysmal rates 12 months later, where if only a third of kids are using their medication a year out, we're in big trouble in terms of relapse and recurrence. So when bipolar disorder, when mania presents in a young population, especially when they're trying to individuate, treatment adherence becomes a central component of their stability and their ability to transition successfully into adulthood. So this is where psychotherapy becomes a very important tool to promote calmer waters, let's just say.
Right. What do you think about I completely agree with you about the chaos. I mean, let's face it, these are biologic illnesses, so you might have family members who maybe are not full bipolar, but have trouble with impulse control and emotional reactivity and maybe ADHD and so on. What about parent training? Psychoeducation, I think, is huge. What about parent training or something like some version of that?
Yeah, it's why
Parent
we
skills,
think family-focused therapy winds up being really useful in some ways, because you get the parents in there they're participating. They're getting the psychoeducation about the condition and what are the tools that are necessary for effective stability and relapse prevention. They get a training on communication skills, how to effectively communicate, especially with episodes, because you can imagine how the communication skills might vary with episodes. And then what it does is there's a module dedicated to problem solving, which is really important for, getting into the business of the day-to-day living challenges that patients experience with bipolar disorder and living with other people who might have, symptoms. And so the family-focused intervention enables the families to work actually as a team to solve problems like who's going to wash the dishes tonight, or how are we going to work around the schedule shifts? I mean, life is hard. To add mania and depression and pharmacotherapy to the business of everyday life is not trivial. And so it really does require a family system, a village, if you will, to manage these symptoms. And the complexity of that is well understood from a theoretical perspective. But for these patients and families to be able to not just, and this is another reason why we think about collateral and the support, the caregiving support that's necessary, even for adults living with bipolar disorder, that it often takes that community support to be able to implement stable outcomes. So I think that, my experience clinically, the parent training is part and parcel of the psychoeducation piece. But if you can implement it in a psychotherapy so that the patient can feel supported, that's great. There are some instances where, you don't want to double dip, and patients often need, their own therapist. And so if individual therapy layered on a family systems therapy can be validating for the patient so that they can have their individual work and their family work, that can be great. But when resources are so limited and patients can barely get any single therapy, it's a dream if you can get multimodal therapies, right?
Yes, no, absolutely. And along with the things we've been talking about, I would think conflict resolution is so important because these are people who can have trouble managing their anger and how to deal with conflict.
Yeah.
So that would be...
That's usually what's covered in the communication skills, you bet.
Communication, yeah. Okay, I'm very curious about this next question I want to ask you, which is, how does bipolar disorder evolve over time from pediatric through adolescence into adulthood? We've touched on this sort of, but let's talk about this.
So over the course of the lifespan, you can imagine that a predominant polarity might, be manifest. In adolescents and young adults, we see a lot more mixed features, more of a juxtaposition. It's almost as if, mania is trying to declare itself, but it's not quite there yet. And then, you have your bimodal distribution of very common mania spurts in the transition age between adolescence and young adulthood, and then middle age. And so, depression tends to predominate the lifespan course, which I think is another reason why we need to do more to meet that unmet need for patients. But a lot of patients also spend a lot of time euthymic. So one of the other ways that we're thinking about how do we test new treatments and how do we monitor treatments for patients who live mostly well, is it time to euthymia that might be a useful measure or metric to be thinking about rather than a time to relapse? Or do we want to think about the long-term maintenance based on, again, the general, like your question is asking or posing, what do people live with at different phases of life, right? And how do we match the treatments according to that life trajectory? Unfortunately, Andy, I don't know, and this may be my limitation and ignorance, is that we don't really know enough about the course. We have some studies that have looked at the longitudinal course of bipolar disorder, but some of it is just that there's some cohorts, we've got some information here and there, but we really need a consolidated, continuous lifespan study, of a lot of patients with bipolar disorder. Melvin McInnes at University of Michigan has this aspiration, and I agree with it. I think we need to do more lifespan work in bipolar disorder to really understand these patterns so that we can do a better job of supporting our patients and families. But from a mood perspective, I think that Kraplin's understanding of that life course is pretty spot on and remains to be the case, that we start with mixed, we have these bursts of mania, and then depression tends to predominate the life course, if not euthymia.
Boy, that's really helpful. Yeah, it occurs to me as you're saying this about the long-term studies, we have that for cardiac outcomes, for instance. We have these kinds of studies for other conditions that we deal with. And when you're dealing with the brain, which is so complicated, and we're talking about neurodevelopment layered on top of mood instability and a pathologic process. So you're right, it's just a lot of moving parts here to understand. But something that I was taught, I don't know if you agree with, is that we shouldn't let people stay manic or psychotic or depressed because they're all bad for the brain. So the euthymia, I think, is to be cherished as much as we can get it and maintain it. Yeah.
And we should be thinking about functioning, right? We want to think about functioning and quality of life, and and how do we get to that and create a quality of life for patients that they can really enjoy. I mean, that's really our goal at the end of the day. It's remission, but it's also thriving. So some of the well-being concepts, I think, are worth us considering, not just from the lifespan course perspective, but also we should be ambitious about expecting well-being even in young people because they have their entire lives ahead of them. They should be hopeful that they can lead functional lives with this condition, and we should be developing treatments that enable that.
Sure, and they're learning relationship skills because relationships are so critically important. They're also learning what kinds of things do I like to do for fun, hobbies, these kinds of things. I think we sometimes neglect that part of someone's life. We don't talk enough about, we're always so focused on school and work and this kind of thing, and yet to be well is to be able to...
Or the impairment.
Impairment, rather, you're right, rather than focusing on strengths. I want to go back to something really quickly because I think it's important too, and I don't mean to sound too medication focused, but are there strategies to monitor and manage medication side effects that might be a little bit different in the pediatric population?
Well, kids are more susceptible to side effects compared to adults. So you absolutely need to do monitoring. And Christoph Carell and others have done an amazing amount of work to signal the importance of monitoring weight gain and metabolic syndrome in youth, particularly since the first-line treatments that we have that are FDA approved for mood stabilization for youth are dopamine 2 antagonists that have this unfortunate risk. And so there's now been a large clinical trial that was funded by PCORI that Christoph Carell and Melissa Del Bello completed. The data and readouts for that are hopefully imminent, but that, whether or not lifestyle treatment versus metformin adjunctively are important for co-prescribing. And so monitoring the side effects, not just weight gain, sedation, but also movement disorders, like you said, Andy. Kids are highly susceptible to those as well. And so dosing is a big key to that, and dose titration and careful. It's like in kids, it's the start low, go slow phenomenon, but definitely don't stay low, because what we tend to do with kids is be so gingerly that we don't get to a therapeutic dose. So we have to rely on the package insert of these medications that have been approved by the FDA so that we know what the safe dosing strategies are for kids. The pediatric dosing parameters are all available in the package insert. So that can be a really useful guide. Our patients and families are very useful. Oftentimes they tend to over-report adverse events because they're sensitive and they're really tuned into that, especially if they've got comorbid anxiety. So be patient and thoughtful and responsive to your patients, but don't give up too quickly before trying to push the medication to a therapeutic dose.
Yeah, that's a really good point. That's something I see all the time with ADHD is people underdose, and there's no one-size-fits-all dosing. Some people may be faster or slow metabolizers, and these drugs are not clearly weight-based. They're not necessarily milligram per kilogram. I feel like you sort of have to just dose them clinically until you either get an effect or a tolerability issue. But I learned something.
Well, what you shouldn't do,
Yes?
is dose it based on adult guidelines.
Oh, sure.
I wrote the first case report of aripiprazole when it was being dosed in kids exactly the way adults were, and kids were coming in with acute dystonia like you wouldn't believe. And so lots of lessons learned there that we should be very mindful of. These are not trivial drugs that ought to be just extended or extrapolated to youth. We have to make sure that the safety signal is okay. Yeah,
good point. I learned something from you every time, Manpreet. I learned that I can use metformin in kids. I would not have thought of that. So thank you for sharing that. We're running out of time, darn it. It always goes so fast when I talk with you. And I just want to leave the audience with a couple of things. First of all, what would be some ways to ensure continuity of care in the transition? Because certainly there's childhood, there's adolescence, but then a real big transition, of course, is finishing high school or going off to college or starting a job. Are there things we can do to try to help negotiate that?
Yeah, I mean, this is somewhat challenging because academic centers and clinics are often oriented around pediatric or child and adolescent clinics and adults. But don't forget, child and adolescent psychiatrists are board certified in adults as well. And some of it is scope of practice, and we really don't want kids to fall off. I think of it just the way that I think of my sister who has Down syndrome, and I thought that I would take care of kids who grew up to be adults with chronic illnesses. And those are the patients that we see in child and adolescent psychiatry who have severe, persistent disorders that need to be managed into the transition to adulthood. Now, say you're a child and adolescent psychiatrist and you don't want to treat a pregnant patient. Well, that makes sense. You want to create some boundaries around your scope of practice. I don't fault you for that. But I think we do need, as a field, to reimagine how we're going to help these patients transition safely into adulthood and not cut them off arbitrarily at 18. It's the rental car companies that got it right when they said, you can't rent a car until you're 26, because they understood that brain development doesn't magically stop at age 18, right? So we have some work to do to make sure that we really support kids through those transitions. And I think colleges, we can't rely on college mental health to do that work for us. We're building on that, but we really need to really shore up and reinforce. So we actually did a clinic in, we were so passionate about this. Terry Ketter, who's now since passed, but developed this really amazing free consultation for college students to get an evaluation for mania. And so we called it the Fair Start program because we wanted to give patients who are first episode manic a fair start. And we've even published on this because it's such an important area of unmet need. I hope that more people get into the business of understanding that mania occurs around the time of transitions, and we need to reinforce that clinically. And so I hope my adult psychiatry colleagues and my child and adolescent psychiatry colleagues can partner with me on that front.
Sounds wonderful. I love leaving on a hopeful note. And I want to throw out one other resource that I certainly give to every patient and family, and that's an organization that our friend Roger McIntyre is on the board. It's the Depression and Bipolar Support Alliance, the website dbsthewordalliance.org. Are there any other resources that you would recommend?
The National Alliance for the Mentally Ill, or NAMI, is another national organization that's great. And I couldn't agree with you more with the DBSA. And psychoeducation is so important. If you look at the American Academy of Child and Adolescent Psychiatry website, we have parent medication guides now that are out and across a variety of different conditions. And we're constantly updating resources on that site too, so that parents and patients can be educated about the topic.
Sure, that's a great tip. And also the DBSA website, families are always wondering, what can I do to help my person, or what should I look for, and this kind of thing. And they have all kinds of information like that. I didn't realize that the American Academy of Child and Adolescent Psychiatry had resources like that too. That's a great tip. Thank you. Well, Manpreet, unfortunately, we're out of time, and I hope this has been helpful to our audience. Are there any final words you'd like to leave our audience with?
Evaluate for mania whenever you see someone with a mood syndrome. Every single instance, missing mania can be very consequential. So I hope you'll take that takeaway message to heart, and realize that a lot of patients with bipolar disorder, even at an early age of onset, have a whole thriving life ahead of them. Let's cultivate hope in those patients and engage with our industry partners and others who are developing novel therapies, because I think the next new therapies that are around the corner are going to provide a lot of hope and a lot of functioning for our patients living with bipolar disorder. I love that. And I like to say, look, bipolar disorder is not a death sentence. It is one of the conditions that is compatible with a normal, healthy, functional life. So I like that we're leaving on a message of hope. And I want to thank you all for listening. For more information about other podcasts and other meetings and educational products and services that we have at NEI, please go to our website, which is www.neiglobal.com. Manpreet, thanks so much. My pleasure, Andy.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.